So welcome everyone. I try to introduce myself to many of you and say hello to those of you whose names I can remember, and say hello to those few of those names I can't remember. I want to thank my colleagues and John Nash, who's really driving force of organizing this, John Franklin, who helps run the local CF Foundation, and the staff in the local CF Foundation. CF Foundation is really the keeper of the hard work and the optimism that's going to make a huge change in the life of your young ones. So I'm ever appreciative of the energy that they create nationally. So my job is to try to keep you awake for about 25 minutes. I'm going to give the kind of nerdy background about kind of what a gene is and how we talk about them. So when you listen to Dr. Comer's talk about new therapies and therapies that are in development, it'll hopefully make a little sense, and I'm going to try to go slowly. I'm not a geneticist by training, so even in my career, some of this is new language, but it's also fascinating because I've been forced to learn this new language because of how much we're learning about CF, from the very tiniest part of it, which is the gene, to how it affects organs and cells and the whole body. And then if we think about what John just said, how we're dealing with improvements in care as a community, it's just been a fantastic part of my career over the last 20 years or so. And it's one of the many reasons I'm enthused about coming to work every day. So let me just say a few words about genes. You know, within the last few years, the Human Genome Project was concluded. We have a lot of genes. They make us, you know, who we are. As you probably remember from your high school biology class, the genes all live on 23 very orderly chromosomes. Half of them come from mom, half of them come from dad. It's a very complex biologic system. Of course, as is often the case with biology, as soon as you solve one puzzle, you realize there's 5 things you don't understand. And I think we're going through that as we try to understand the human genome. And as you probably know, this is called an autosomal recessive disease. We know there are many other. Sickle cell would be another common example. And the transmission means that one abnormal gene from mom, one abnormal gene from dad, and these are the statistics in terms of across a population what that genetic pattern looks like. And of course, you know, these are the kids we're interested in, these are the adults we're interested in, and understanding the genes that affect CF, that cause CF, has just opened up huge opportunities for improvements in developing new medications. So I'm going to take a little bit of a journey. This is corny, genes to genes. Get it? That's a joke. Well, let's look at these siblings with CF, and they're in genes. And let's take a look at the lungs. So, of course, CF affects other organs besides the lungs. So some of what I'm going to say is translatable to the other organs. But, of course, it's really the pulmonary disease that I think gets the most attention, of course, deserves the most attention, because I think more than any other aspect of CF, it's the lung health, which determines quality of life, and it's lung health, of course, which keep our patients active and doing the things they want to do. So, I'm older than most of you. There was a movie called Fantastic Voyage, where they miniaturized a submarine, went to the bottom. It was with Raquel Welch. I'm really dating myself. So let's take that kind of journey. So let's look into the lungs here. Here are the lungs, and they have air tubes called bronchi and air sacs called alveoli. You don't have to remember any of this. And of course, within that system are tubes, and those tubes have cells on them. So let's go one level deeper. So these are the cells in the airways. So this is a tube. You can see the cells depicted in blue there. They have little hairs on them. Those hairs are very important. They're called cilia. I'm not such a good artist. And cilia are very coordinated parts of the cell that beat in a certain direction. And we call them an elevator. So if something, whoops, falls into the lungs, of course we're always inhaling stuff, even now. it's often caught up in the cilia, and the cilia and the lungs beat up this way, so someone can cough it out, or sometimes swallow it. Of course, the acid in the stomach is a good protective environment to kill things that might get down that way. And in the nose, the cilia beat backwards, so again, it can come back this way and be coughed out. So it's part of a very robust system that helps us keep our lungs clean. And that's one of the cilia are one of the things that don't quite work right in CF. Now, the cilia themselves are fine. There's another disease that causes bronchiectasis, this kind of inflammation in the lung. There's called hematocilia syndrome. So the cilia themselves are working. So one of the jobs is to try to make sure the environment that the cilia live in are working properly. So let's take a look farther down. And here's an archetypal cell. I'm going to be using this as, I hope, a simple model. And I've labeled 3 parts of the slide. There's the nucleus in red. That's where the DNA lives. That's where the chromosome lives. That's where the genes live. And then there's a halfway point called the endoplasmic reticulum. And I was thinking, could I make a joke about emergency room? And it's really not. It's a place, it's like a substation where the proteins made kind of get fixed up. And not just the protein involved with CF, but many of the proteins in the body. And from the endoplasmic reticulum, the protein, in this case we're talking about the protein that's critical in CF, goes up to the cell surface. And you can see that brown triangle, which is meant to depict the critical protein we're going to be talking about today, sits up there with the cilia. And that protein, the CFTR, the channel, which is of such great interest to us in CF, is a channel, it's a port, and things come out of that port. So chloride comes out of the port. You may hear us refer to it as a chloride channel. And actually bicarbonate comes out of that port. And other chemicals, ATP comes out of it. There will be a test on this, I told you that, didn't I? And as it puts out all that stuff, it actually bathes the cilia in just the right amount of fluid, and that fluid has just the right constituency. So there's a nice dance that goes on between the stuff that comes out through the CFTR, the CF channel, and that cilia, they're doing their dance to help keep our lungs clean. So the genes in the nucleus tell how the protein is made. The protein is made, it travels up to the endoplasmic reticulum. It's fixed up there, and then it goes up to the cell surface. So this is a normal cell. And here's the proper name for CFTR, cystic fibrosis transmembrane conductance regulator. And as I say, it's the key protein that we're interested in when we talk about the genetics and the protein analysis of cystic fibrosis. So let's keep going here. So how are proteins made? So we all have genes, and genes are packaged in a very orderly fashion onto 23 sets of chromosomes. As I said, one set from mom, one set from dad. Genes have specific proteins that they make. So if you remember, there's probably over 30,000. We've got a lot of proteins in the body, and some are the ones that make up the collagen in the bones. Some are helpers. They don't actually get incorporated into the body. They help move other proteins. And as I said earlier, the more we know, the more we realize we don't know, and that's always the yin and yang of basic science. But the genes have a blueprint for one particular protein. So they have the code for it. And it's very orderly. So the gene for CFTR, this protein we're interested in, is always on the same chromosome. It's always in the same spot. And that order is very important. So they're in specific sites. And as I say in the small print, the CFTR happens to be on the long arm of chromosome 7. That's not so important to understand this, but it is very orderly. It's always in the same place on everyone's chromosomes. Once the gene makes the protein, as I said, the protein goes out into the cell. And proteins are very complex kind of thread-like structures. And to work properly, they often have to be folded into place. And we're learning that that folding is critical to make that protein work properly. And that's one of the jobs of the endoplasmic reticulum. So you make a protein, it's a long string-like thing, it gets fixed up so it has just the right configuration that it can do its job and interact with other parts of the cell. And then once it's folded properly, it goes where it needs to go. So let's go a little farther. Oh, I love that. There's a nucleus bouncing around there. And this is an actual picture of the 23 chromosomes from a human. And as it turns out, you can see it from back, 2 of them are purple. Those are chromosome 7, so somewhere on those are the gene that codes for the CFTR. If it's a normal cell, then the CFTR is working normally and making that protein normally. If it's a patient with CF, a person with CF, then that gene has an abnormality in it, a change in it. And I've already said this, 23 sets, mother and father. As I said, there's a very specific code that goes on. And you may hear the term genome. And genome is a term, a scientific term, that basically refers to all the genes that an individual has. So as you know, there's a Human Genome Project, and we kind of understand the human genome, but most of what everyone has in this room, of course, is the human genome, and there's specific similarities. On the other hand, someone back there has a red-headed gene, someone there has maybe a left-handed gene, someone there has, anyone can roll their tongue. I think there's a gene that you can roll your tongue, or if you're double-jointed. So there's probably a lot of controls that make us all the same, but also very different. So that's when you hear the term genome, it refers to the whole package of that genetic material that's contained on the chromosomes. So let's now talk about the specific gene and protein we're talking about. So I've said that the gene for the CFTR is located on chromosome 7. And this is a picture of chromosome 7. And there's the unraveling DNA. And the DNA is, of course, the basic stuff, the basic building block of the genes. And I've said all this before, but the CFTR gene contains the information to make the protein. The protein goes up to the cell surface and keeps the lung clean. So the research, the tremendous research effort that's gone into understanding the gene and the protein makes sense, because we understand actually where the problem is with CF. We have a much, much better chance of coming up with good and novel therapies that will actually either fix the gene or fix the protein. And that's the age we've just entered with some of the new drugs that Dr. Comer is going to talk about. So the CFTR, as I said, comes out. I've used that little kind of burst to show the improperly folded CFTR that comes out of every one cell in this room. That goes to the endoplasmic reticulum, where it's fixed up in a very orderly fashion, and goes up to the cell surface, where it does its dance with the fluid and the cilia to keep the cell working properly. So then all the right stuff comes out of that. In CF, that's missing. The CFTR doesn't get up to the cell surface. And the way I've pictured it here is the cilia are pressed down, they're tired, they don't work carefully. Some of those circles are meant to be molecules of mucus that our patients work so hard to cough out. Some of them represent the bacteria, which cause inflammation. So these are meant to be emblematic of the process we're trying to improve and cure. So most of the therapies that we have, very effective, are meant to reduce the mucus production, kill off or hold down the bacteria and reduce the inflammation. And I'll mention some of them because these are familiar to all of you. So our patients inhale DNase and pulmozyme and hypertonic saline to try to thin and get up the mucus. They inhale antibiotics, including tobramycin and aztreonam, and sometimes some other antibiotics to kill off the bacteria. Sometimes children will take high doses of ibuprofen, and a lot of patients take azithromycin. These are all aimed at reducing the inflammation in CF. So without really dealing with the gene and the protein, we have fantastic treatments for CF. They're very arduous, and any of you who live with a person with CF knows the amount of work that goes into it. And they work pretty well. They've really helped improve longevity, as John's first slide showed. So understanding this part of CF has been critical in getting us where we are. And one of my messages is keep with this stuff. Don't leave it yet. We're not quite there. So let's talk about the CF gene. So it turns out it's a big gene. So there's some small genes and big genes. So this has just more little particles along that path of DNA than others. And of course, every time you have more of that genetic material, there's more chance that one of the proper codes is going to be flipped, and that what leads to the mutations in CF. So because it's a big gene, it turns out there are a lot of mutations. And there are over 1,000 mutations that have been identified causing CF. So it's a lot of biologic information material that we're trying to understand and tame. And there's a fantastic project, I'm going to talk about this in a few minutes, down at Johns Hopkins, where they're trying to categorize all the different genotypes, all the different types of mutations that can affect patients with CF. So every patient has a specific look to their CFTR gene. And we give a name, and the naming is complicated. I'm not going to spend very much time talking about that. So we give a name to the altered gene that comes from mom, and the altered gene that comes from dad. And there's two parts to that name, kind of a first name and a second name. And that's the person's genotype. So I'm sure some of you in the room have heard your child's, your relatives, or your loved one's genotype. Certainly you've probably heard of something called Delta F508. That's the most common mutation. But there's a whole library of mutations. I'm going to tell you how you can look some of this stuff up on the internet. Turns out that over 80 patients have either one or two copies of the Delta 508. So by far, that's the most common of the mutation. And it also turns out that mutations affect CF differently. And of course, what we'd like to do is, look at a patient, say you have mutation A and B. We know that you're going to be sick every 3 months, and that your pancreas is going to be very bad or not so bad. And it turns out that the correlation is not that tight. And we know that certain mutations lead to a slightly milder disease, but even then there are always exceptions. So we don't actually spend a lot of time looking at patients saying you have a certain genotype and you're going to look a certain way in a year or look a certain way in 2 years. As I say, it's just the linkage isn't one-to-one. So we don't look for that. We still have to be aggressive in treating the disease and put in as many preventive measures as possible. So as I said, different mutations affect CFTR differently. Turns out that different mutations do different things to CFTR, and we've categorized these into classes. So in some of the classes, no CFTR is made at all. Nothing gets out of the nucleus. And if you think about it for a sec, that's the perfect patient for gene therapy. So magically, if we can inhale a normal gene, it can insert itself into the lung, then you'd have normal genetic material, which would be making normal protein. And that ship hasn't come in yet, but it may well come in. So I think when the gene was isolated in 1989, there was great hope that that was going to be the one cure for it. And it turned out that the engineering is complicated, but there are still centers here in the United States and Britain looking at that. So there's still interest in gene transfer, and we may be sitting in front of you in 5 years talking about gene transfer. So that's interesting, and that may happen. There are companies, however, look at little molecules that may actually kind of insert themselves and sit on the gene and kind of do some repair right there, and let the abnormal gene in this class of mutations that don't make any protein kind of force the DNA to work properly and pump out normal protein. In other kinds of mutations, the CFTR is made, but it doesn't go to the cell surface. And that's the case with the delta 508. I'm going to show a picture, the cartoon of that in a second. And then there are other mutations where protein is made, it actually swims around the cell, but the misfolding of it means it doesn't work right. And we've actually broken those mutations down to 6 types. Now it's very interesting. If you read some scientific papers, and I've been reviewing to get ready for the day, they say there are 5 types, some say there are 6. So we're still struggling with where to fit certain proteins into this scheme, so it's not quite perfect yet. But certainly we understand that different mutations result in different abnormalities of that CFTR protein. And this is a cartoon that I think explains some of this, and I'll take you through it. So on the left-hand slide here is a normal cell. And these stippled circles are meant to represent the protein CFTR. They come out of the DNA. This is the endoplasmic reticulum where it's fixed up right, it's folded right. It then swims through the cell and goes to the top of the cell. You can see there's a channel there depicted in the cartoon, and that's where the stuff comes out. Then we can take the different 4 or 5 different mutations in type 1 I've talked about. No protein gets out. So either gene transfer would work here, or some very small molecule that can get into the DNA and kind of fix it up, almost put a Band-Aid on it so it works. In the type 2, which includes the delta 508, so this is certainly by far the most common type of mutation, the CFTR is made, here it's depicted in the box, to represent the misfolding, and it just gets stuck. And the cell actually digests it, because our cells want to get rid of abnormal protein, which doesn't belong there. There's a so-called type 3 mutation where protein is made, it gets to the cell surface, but it doesn't open right, it's kind of locked. And there's great interest in this as so-called type 3 mutations, which includes the G551D. Now, I'm starting to use some of the nomenclature. I don't want to use a lot of gene names because I don't think they help very much, but certainly 2 mutations that you may have encountered either talking with us or doing some search on the internet or reading are the delta 508, the common one, and the G551D. And that was the type 3 mutation that's become the target for the new drug, Aptor, and I think Dr. Comer is going to talk more about that. Yes, Paul?
Yes, sir.
So you can hear more about the biology. And then we have the 4, 5, 6 mutations, and you can see that protein is up there, there's a channel, but it doesn't quite work right. And it turns out, in terms of correlating types of mutation with how severe the disease is. And again, I don't want to overstress this because, in fact, there is not a good one-to-one correlation. In general, patients with these types of mutations have somewhat milder disease. And I just want to say, and I'm going to repeat this again, the last year's CF meeting, as we looked at slides and data like this, Bob Bell, the head of the CF Foundation, stood up and with great conviction said that the CF Foundation is committed to curing every type of mutation. And that's a great thing for us to hear in this community, because we want to afford all the advances to every patient, not just a small group of patients. So this is kind of the basic cartoon, the basic scheme that helps us understand that within that genotype of CF, there's actually a lot of variation. So every patient is somewhat different. And this is just a table recapitulating what we've just gone through. and actually I can print this up and hand it out in clinic, although this comes from, this I actually found the CF Foundation website, so this is available to you. So types 1, 2, and 3 are described there, and the so-called atypical classes are listed below. Now, no one can see this slide, but every year the CF Foundation puts out the distribution of, is that a question back there? Feel free to interrupt. Every year the CF Foundation publishes the frequency that we see certain genotypes in the population of patients they follow. And this is a list of it. I've actually blown it up so you can see it, the top view. And I've talked about the Delta 508. You can see that almost 87% of patients either have one or two of those. And then coming down, G542X, G551D, that's the mutation I talked about in terms of being the target for ivacaftor or kalydeco. So we have some idea of the distribution of these types of genes in the population of patients that we deal with and across the country, and they're actually international databases. Up until a few years ago, I didn't really, it was always interesting to know a patient's genotype, but because it wasn't going to change anything I did with the patient, it was more of a curiosity. And of course, curiosity will sometimes lead to good scientific discovery, so I don't want to dismiss curiosity. But as of the release of this drug, now it's important we know what genotype a patient is. So number one, if they're eligible for this new drug, they can get it. And maybe just as importantly, as we try to develop new drugs aimed at certain parts or new therapies aimed at certain types of genotypes, we know which patients to call on to be in clinical studies. And there's been a fantastic commitment on the part of the CF Foundation to make sure every patient in the country is genotyped. Now, this is a screenshot of an interesting website. I would urge you all to jot this down. This is called CFTR2. It comes out of Johns Hopkins. And Johns Hopkins has linked up with the CF Foundation and a genetic sequencing company to join in the effort to genotype every patient in the country with CF. And as you can see in the bottom, I don't know if you can see it here, this green box says for CF patients and families. This has, I think, less technical language. This is for physicians and scientists, I think more technical language. And they have a little blurb on every genotype, and I'll show you a couple of those in a second. I'm not sure it's that helpful, actually. They're purposely not saying what class the mutation is, because I don't think they want a mad rush to get too focused on this for patients yet. I think the best thing about this website are the links. So I think the two websites that I would recommend are the CF Foundation website, and I think this website is definitely worth looking at.
I didn't quite hear what the website was.
So it's out of Johns Hopkins, and if you just put in your search engine CFTR2, the number 2.
Yeah, it's www.cftr2.org. Yeah.
I can never remember that WW stuff, so.
I can't remember where there's 3 or 4 W's.
There's another one in Toronto, but I actually think this is a much better website for patients and families. So I'm just going to show you a couple more screenshots, and I'm going to let Paul get up here and tell you about the exciting stuff. So I just put in, show all mutations, which I clicked on, and they have them listed in terms of frequency. So you can see that Delta 508 is up at the top there. And if you click on the details, and I've done it for 2 of the genotypes, and I don't know if this projects in the past, so Delta 508 probably takes pancreatic enzymes, and I think they're focusing right now mostly on the correlation with genotype and pancreatic function. And it tells you that in the database in the country, there are about 33,000 patients with this, so this is the common one. You come down, a relatively mild mutation, R117H. And patients tend to have normal pancreases with this. So it gives you a little hint at some of the biologic implications of the gene, but really they're focusing mostly on the digestion. But as I said, I think the best thing about the website is it's a portal to some very good information. So let me end up with a couple of summary slides. So I think every patient should be genotyped, and I think probably at Albany Med, if it's not 100%, it's well above 95% of our patients have been genotyped. Right now, depending on genotype, a few patients, 3 or 4% might have an important medication to take, and those of you who have read about Kalydeco or ivacaftor know that. As we try to develop new medications, having people's genotype is important because that will help us identify the right subjects for clinical studies, and there's a very well organized network of clinical research centers. Dr. Comer did all the work to get us signed up for it, so we're one of those centers nationally. And the nice thing about what I'm talking about is in these new therapies, these genetic and protein-based therapies, we're not trying to fix up the stuff that CF causes. We're trying to fix CF at its basic root. And that is just so exciting. That's why we can use the word cure with some confidence these days. So these changes are happening very rapidly. There's a huge biologic push and from pharmaceutical companies because the misfolding of protein or the misfiring of genes clearly has to do with diseases besides CF. And if we can figure it out in CF, we may figure it out in other diseases. That's also exciting across the medical community. So the message I want to leave you with for your loved ones with CF is while we're waiting for this, keep doing the stuff. Keep washing your hands every day. Get your kids, your brothers, your sisters in their vest. Yell at them so I don't have to. Certainly understand that all this nerdy science, some of which doesn't always work, is really important. The more we understand about the bacteria that infect CF patients, the more we can use the right antibiotics. The more we understand about the way cilia work, the more we can understand how we can whip up the cilia in CF patients. And certainly the more we understand about the gene and the protein, the more we can fix it. Keep yourself informed, because I think well-informed patients and families end up getting better care. Don't be afraid of challenging us. I'm very humble about the amount of information you have access to. And of course, I want to urge everyone to support the CF Foundation, which is at the heart of getting the cure. So I hope I've made the science and the basic background understandable. And the exciting talk, of course, is going to come from Dr. Comer, who's going to talk about how some of this basic science translates into new therapies. So thank you for your attention.